Parkinsonism is a disease of the older people, 2% of the elderly people actually, in the seventh decade of their life, which is due to the result of neurodegenerative changes in the dopaminergic nigrostriatal pathway, leading to three classic symptoms that are bradykinesia, muscle rigidity, and resting tremor. Now, the etiology behind Parkinson's disease is the imbalance between the acetylcholine and dopamine that is disturbed by neurodegenerative processes. There is a balance between dopamine and acetylcholine in the basal ganglia, the nigrostriatal pathway. But in Parkinson's disease, what happens is that there is degeneration and decreased dopamine while acetylcholine is increased. So the classic three symptoms, the bradykinesia is due to the lack of dopamine because dopamine inhibits inhibitory neurotransmission that leads to initiation of movements, while the other two symptoms, the muscle rigidity and the resting tremor, is due to increased acetylcholine acting on the muscarinic receptors. Let's see the two types of dopamine receptors, D1 and D2. D1 is GS coupled and D2 is GI coupled. DI is present in blood vessels and CNS, while D2 is in the chemotrigger zone, pituitary, and specifically D2A is present in the nigrostriatal pathway, while the D2C is present in the mesolimbic pathway. Now here I'll show you how the imbalance between increased acetylcholine and decreased dopamine causes the Parkinsonism symptoms. There are three neurons shown here. One is cholinergic, other is dopaminergic, and third is GABAergic. Now we know that the GABA releasing neuron is an inhibitory neuron, right? So dopamine released by the dopaminergic neuron is actually playing the excitatory part here because it is inhibiting an inhibitory neuron, while the cholinergic neuron, by releasing acetylcholine acting on M3 receptor, which is GS coupled and stimulatory, will stimulate an inhibitory neuron, leading to inhibition. And we don't want that because the inhibition will cause the akinesia. And as I already mentioned, the increased acetylcholine will cause muscle rigidity and the resting tremor. The resting tremor should be differentiated from the intention tremor, which is a manifestation of cerebellar disorders. Now let's see where we can put the anti-Parkinsonian drugs on this diagram. Firstly, we can increase dopamine synthesis and release by giving dopamine precursors like L-DOPA. Secondly, we can give dopamine receptor agonists to act on the dopamine receptor. Thirdly, we can inhibit the MAO-B inhibitor, which is responsible for the degradation of dopamine. We can inhibit this enzyme. And fourthly, we can also block the acetylcholine receptors, that is the muscarinic blockers, to decrease the cholinergic activity. Now, one thing I needed to clarify before going to the classification of anti-Parkinsonian drugs was that the prodrug that we give, that is converted ultimately into dopamine, can cross the blood-brain barrier while dopamine cannot. So we give levodopa, which is converted by aromatic amino acid decarboxylase into dopamine in the central nervous system where we need it. Now the problem is we don't just have this aromatic amino acid decarboxylase in the central nervous system, we also have it in the periphery. And when it converts the levodopa into dopamine in the periphery, it not only wastes the drug but also leads to loads of side effects due to active dopamine in the periphery, causing vomiting due to its action on the chemotrigger zone and as well as the blood vessels. Now, to make matters worse, there's another enzyme in the periphery as well as in the central nervous system known as catechol-O methyltransferase, which will convert the levodopa into 3-O-methyl-dopa. And that means that levodopa availability will be decreased, and 3-O-methyl-dopa is actually a partial agonist, and in the presence of dopamine, it will act as an antagonist. So we have two problems here. One is the peripheral AAA. This is AAA, not double A. One is the peripheral AAAD enzyme and the other is COMT enzyme, both in the CNS and the periphery. So we need to inhibit peripheral AAAD and central and peripheral COMT. We do this by certain drugs that I will mention in the classification. Also, dopamine in the central nervous system will be degraded by MAO-B enzyme that I already mentioned into its metabolites. So we also need to inhibit MAO-B enzyme. Now that we have a base to work on, let's come to the classification of the drugs used in Parkinsonism. One class of the drugs will act on the dopaminergic system, increasing dopamine, and the other will act on the cholinergic system to decrease cholinergic activity. The dopaminergic system will include dopamine precursors, dopamine agonists, NMDA receptor antagonism, MAO-B inhibitors, and COMT inhibitors, as I mentioned a while ago. While the cholinergic system drugs will include anticholinergics and antihistaminics because they also have antimuscarinic properties. Now, the first class of the drugs, the dopamine precursors, the main drug is levodopa. We do not directly administer dopamine because dopamine cannot cross the blood-brain barrier and enter CNS. So we give a precursor, that is levodopa, and it is converted into dopamine by the AAAD enzyme in the CNS. But as I already mentioned, we need to give it with a peripheral AAAD enzyme inhibitor, which is carbidopa. The adverse effects, nevertheless, can be there due to increased dopamine in the periphery and in the central nervous system. Increased dopamine in the periphery will cause chemotrigger zone stimulation due to the D2 receptors present on the chemotrigger zone, causing nausea and vomiting. Its central effects will cause anorexia and weight loss due to increased dopamine. The cardiovascular system will manifest hypotension, tachycardia, that is reflex tachycardia, palpitation, and cardiac arrhythmias due to the D1 receptors on the vessels. Dyskinesia can also be seen due to the excess dopamine and involuntary initiation of movements, leading to hyperkinetic movements. There can be taste alteration and mental changes due to the stimulation of mesolimbic and mesocortical areas of the brain, leading to insomnia, euphoria, hallucinations, and nightmares. Now, with administration of levodopa, a phenomenon known as the on-off phenomena can be seen, which is basically a fluctuation in the response of the drug. When there is the end of dose, there is an off response, like a switch is turned off, and there is loss of beneficial effects of the drug. And when the drug is administered again, the symptoms become normal. That's why a sustained release formulation should be advised in such patients. The next class of the drugs that can be used on the dopaminergic system are dopamine agonists. The chief drugs are bromocriptine, ropinirole, and pramipexole. They have a direct action on the dopamine receptors, and they have an increased duration of action than the dopamine precursors. Bromocriptine has a D2 agonist action as well as a D1 partial agonist action. It is an ergot derivative, while ropinirole is a D2 agonist, pramipexole is a D3 agonist, and ropinirole and pramipexole are not ergot derived. The next class of drugs include mainly amantadine. It is basically an antiviral drug used in influenza treatment, but it has an effect on the dopamine synthesis and release as well. It increases its synthesis and release from dopaminergic neurons, and it is usually used in the initial treatment. It also decreases glutamate neurotransmission by NMDA receptor antagonism, and that can contribute to its beneficial effects as well. The next class of drugs are the MAO-B inhibitors. Now, if you remember, I said earlier that dopamine is degraded by MAO-B enzyme. So if we inhibit this enzyme, dopamine will not be degraded and increased concentration will be there in the CNS and help in Parkinsonism. The chief drugs are seleginine and raseginine. And one thing bad about these drugs is that their metabolites are actually amphetamines, and you know amphetamines are CNS stimulants, so they will cause insomnia, anxiety, nausea, and vomiting, etc. The last type of drugs acting on the dopaminergic system will be COMT inhibitors. They are tolcapone and entacapone. They are actually reversible inhibitors of COMT, and they will increase levodopa bioavailability. Tolcapone is both centrally acting and peripherally acting a COMT inhibitor, while entacapone is only peripherally acting. One thing bad about tolcapone is its hepatotoxicity. Lastly, the drugs acting on the cholinergic systems are anticholinergics and antihistaminics. Anticholinergic drugs, as you are well aware by now, are benzhexol and benztropine. They will decrease acetylcholine and have atropine-like side effects like dry mouth, constipation, urinary retention, etc. Antihistaminics are used because they have anticholinergic properties. Okay, and the chief drugs will be orphenadrine, promethazine, and diphenhydramines. I hope it's clear by now. That's all.